So let's start with this presentation. So I like to start with the case of Maria. Maria came to my practice from the clinic, I think 2-3 years ago, and she was sent a revert by another colleague. And she was asking me, Daan, there is some problem with this lady. I did some accessory movement there on the jaw. She has some pains, what you can see here in the body charts, and it's still there. Can you help me? So what I do now here, you can see the body chart, and it's very clear that she has on the body chart pins and needles on the left side of the chin. She has pain when she's opening her mouth, when she's opening her jaw, what you can see in the blue area here. It's around, let's say, 30 millimeter. And at the end of the opening, she had a restriction of her jaw in the green area. Yeah, so pain with opening, mainly pins and needles on her chin, only on her left side. Again, she did accessory movement there. She did some techniques on the masseter. She did some techniques on her muscles, but it was still there. And the question to me was, Dan, can you look a little bit further? Because it's still there. It doesn't fit. Can you help me? So I'd like you to remember this case of Maria, where I come back later in this presentation. Because we talk now about peripheral nerve tissue, I think it's important to understand what is peripheral nerve if we compare it with the central nervous system. So definition from the International Association for Studies of Pain is that it's pain or nociceptive input from peripheral nerves, which is outside of the dorsal horn or brainstem. Yeah, so when it's coming out of the brainstem, we call it the peripheral nerve. When it's coming in, it's still the central nerve system. And the same what we can see in the dorsal horn. Inside is central, and outside it is the peripheral nerve system. So that's where we talk about today. We know also from the International Studies of Pain that pain can cause, it's another definition, by a lesion or a disease of the somatosensory system. So in the brain itself, and what is the reason that the peripheral nerve is irritated or damaged, or there's a problem there. And it gives symptoms and pain to the patient. I think most of you are familiar with some neuropathic pain in the orofacial region. For instance, the trigeminal nerve. Mostly it is the mandible nerve, but also think about the maxillary nerve. Another nerve could be involved in this area is the glossopharyngeal nerve. And the glossopharyngeal nerve is a nerve who is making the movement of the jaw. In this case, I have to say it correct, swallowing. Also involvement with vagus nerve. So that's a totally different nerve if we compare it to the trigeminal nerve. And another one is the superior laryngeal neuralgia. And that's another one less, it's a little bit more rare, but it's still a problem what can happen in the orofacial region. So we emphasize a little bit more typical to the trigeminal area. So first, I'd like you to see the classification. So the first one, what I like to discuss is the neuropathic pain with a sensory hypersensitivity. The second one I like to discuss is the compressive neuropathy or compression neuropathy. That's number 2.
Jace, voor je mij? Jace.
And the third one is the peripheral nerve sensitization. So these 3 in the classification I like to discuss. Is this new? Yes and no. It's already there within the International Association of Studies of Pain. There was a special interest group already some 10 years ago, 2013, 14, where they already discussed about upper limb pain and also with leg pain. And okay, maybe it has to be graded. Yeah, so for the presence of pain. So it was already something.
Sorry, Daan. Please, can you close down your microphone? Somebody
Is it too hard?
No, not for you, but somebody is talking on the background. Okay.
Yeah, I can see it. Yeah, I'll hear it.
Okay.
Is this okay?
Sorry. Yeah. Now let's go.
Great. Okay. Yeah. So this is what they already saw at that time. From okay, maybe there is a need for a special grading system at that time. So we also now look more to the orofacial field instead of the upper limb or the lower limb area. So when we look at pain, it's very simplistic, of course. When we look at this drawing, we can say there are 2 typical types of pain when there is an involvement of a nerve. So the first one is nerve injury pain. So that's mainly what we see here when we see the nerve in yellow and blue, that there is a problem of the axon. So we can see the blue lines here in the nerve itself, and there could be an axon problem of the nerve. The other one is more the nerve trunk itself. So let's say here the yellow, the orange area. So that's more the trunk of the nerve. So we don't talk about axon here, but the nerve trunk itself. And also the connective tissue. So that means also a little bit the surroundings around the nerve itself. So there are two typical ways to think about nerve problems. And also it gives a different assessment, a different examination, and also a different treatment. And that's the thing what we like to discuss tonight. So let's start with the first one, the neuropathic pain with a sensory hypersensitivity. What is the reason that this guy here has pain on his head or in his face or maybe somewhere else? So the main cause of it is the model of the neuropathic pain of an AIGS, and it means the abnormal impulse generating site. So that's the classification or the clarification of this system. And it means we see here in this model, we can see the target tissue on the left side. We can see the brainstem on the other side, within the nuclei of the brainstem itself. And we can see the spinal ganglion there, also with different nuclei in that area. And then we can see in the Jorman's arrow that there could be a compression there on the nerve, because the line in the middle is the nerve itself. So there could be a simple compression. There could be an ischemia in that area. There could be a problem because of a trauma. And also very interesting in the AIGS system is that it could be also spontaneous. So nothing had happened, but there is actually a pain on the nerve. And it's quite interesting why it's there. So this is a little bit the classification and also the model of thinking about an NPSH. So when we look about a spontaneous situation, there is already a very interesting study in systematic review and also a meta-analysis in 2023, where they looked already about spontaneous activity of the peripheral nerve situation. So you can see it already here in the abstract that in the peripheral nerve system, there could be a spontaneous activity in the sensory neurons, which is considered to be one of the two main drivers of chronic pain, alongside, of course, neural sensitization. So I think it's important to understand that it could be also a reason that someone has pain besides a neural sensitization itself, specific for chronic pain, but it could be also, of course, in an acute or in a subacute situation. So when we look to the key clinical features, there are some features to increase the confidence of the diagnosis of an NPSH. So that's what I like to discuss in the next slide. So the first one is pain within a district of a neural anatomically plausible distribution. So that means, for instance, a guy who's shaving himself in the morning has some pain around his face and it feels a little bit different. It feels like pins and needles, some numbness, or maybe a little bit irritation. So there is a sort of this aesthesia during a shaving. And in this case, for number one, it could be that there is a pain, a shooting line of pain from proximal to distal in the line of his jaw, in this case for the shaving area, which can give maybe a problem on the mandible nerve. So the first one is the pain within a distinct of neural anatomically plausible distribution. So it could be involvement of the 5-3 nerve, the mandible nerve. So the second one is history. And history, of course, is very important always when we do our subjective examination. History. Very important when we have to listen, and we have to listen to our patient and hear the story. And what we hear mostly, and sometimes we have to ask them extra, is something happened in your history, maybe 1 week ago, maybe 3 months ago, and maybe sometimes 1 year or maybe 2 years ago. And what I hear often in my clinic is what's very familiar, that there could be a tooth extraction there. Maybe 1 week ago, but for most of the patient, it's strange. Yeah, that was maybe 4 months ago, Daan. It's only now for 2 or 3 weeks. And the tooth extraction was maybe, it was around 3 or 4 months ago. So could that maybe the reason for my pain or maybe my tooth pain? Yes, it could be, because there is already a sort of predisposing factor for maybe a problem in affecting the somatosensory system. Also think about, besides the tooth extraction, about a whiplash-associated disorder. Also there, it could be 1 week ago. Mostly what we see, of course, is a little bit longer. That could be 3 months, it could be 1 year, maybe it is 2-3 years already there. Yeah, and we know all that a whiplash-associated disorder can have an involvement in a lot of dysfunctions of the patient. besides pain. Okay, so that's the second one, so a history. The third one is a demonstration of an altered bedside neurological function. So that means when we look, for instance, here in the mandible nerve, or also in this case, the facial skin, we can see that the strength is different. So that could be the facial muscles with the mimic, with expression. But also think about the strength of the muscles itself, what we can test when we look about the muscles for mastication, masseter, temporal, and the pituitary muscles. So we see that the strength is less, and also what the patient will tell you is that, I have a sort of fatigue feeling when I'm eating. I have the feeling it's a little bit more heavy. It costs me more energy to do it. So we see that there is a lack of endurance about the mandible muscles. And there could be, in this case, an involvement of 5-3, the mandible nerve. So that's number 3 in this case. We still talk about the MPSH. So the fourth one is a demonstration of the relevant lesion or a disease by a conformity test. That could be the conduction test, what we can do. I will talk about it later. Strength, what we can test. We can test the sensibility and our reflexes. And in some cases, it is a confirmation by an MRI. Mostly it's already done, or if it's not, there could be also an extra confirmation about that. So there are 4 interesting key features to think about an MPSH. So what is the appropriate clinical testing when we talk about this classification? Think about sensibility, think about motor control, and think about the reflexes. So that means our neurological examination. The same what we do with an upper limb, the same what we do with a leg pain or a problem of the nerves in the lower part. We can do the same, of course, in the oral facial field. We know when we do a sensibility test, we can do this with some soft superficial touch. We can do that with a pinprick. We can do that with other kind of things to test it. And we want to know, is there a sort of dysesthesia? Is there maybe a sort of allodynia or hyperalgesia, where it's more sensitive than normal, or the pain is already there, or I don't feel pain? So there could be a lot of explanations if we see something about sensibility. So that's one. We are familiar with the motor control. We can test it. We can test it with our tests of the jaw in strength, endurance, coordination, and strength. And the other one, of course, are the reflexes. We know the jaw reflex, in this case, of course, for the jaw. We can test it, of course, also in the blink reflex, when the afferent information is coming to the sclera of the eye. It's coming from the trigeminal nerve. And the afferent information, so the action itself, is coming from the facial muscle, who is innervated, of course, by the facial nerve number 7. I'm now talking more about the trigeminal nerve, but also think about other testing, what you can do when we talk about vagus nerve, a glossopharyngeal nerve, or maybe an accessory nerve, who has an involvement on other systems in that area. So quite clear, I think, sensibility, motor control, reflexure, or to summarize it, your neurological examination. Then we have, and maybe that's new for some of you, is the quantitative sensory testing. And the quantitative sensory testing, QST, is something what you can use already in your clinic, or maybe what the doctor is doing in a hospital, or maybe in a specialized clinic. And it is a way of testing the neural system itself. How can the nerve system process on a specific afferent information input? For instance, vibration, think about pressure, think about other kinds of testing what we can do on the skin, and how does the skin react on that, or maybe other functions there. So it's not a new thing. It's already something what they do a lot. But maybe for some of you, it's a new thing, and it's a more specialized way to test other things. Also think about the pressure, what we can test on muscles, for instance, here on the masseter or the temporal muscle with our algometer, and we can test the pain threshold. Is the pain coming very early, or is the pain coming later? And how later it comes, of course, how better it is. If it's already there within a little bit pressure, that could lead already to maybe a sort of hyperalgesia, or maybe there is already a sort of central sensitization. So in summary, the QST testing is something new in this world. And on the other hand, it's already there, but it's, I think, very nice to see a little bit more in a deeper detail when you know and want to know more about it. Yeah, this is also an article that I show you here from Bredewout in 2025, where they also talk about the testing of neuropathic pain and already discussing different names like dysesthesia, allodynia, hyperalgesia, and to give a little bit more detail about that. So maybe an interesting article to read. So we are still in the MPSH at our first classification. We talked about neurological examination. That's a thing what we can do. But less appropriate are palpation or the neurodynamic testing. We can palpate nerves in the face, for instance, here on the mandible nerve. We can do our neurodynamic test, what we can do there. And that's less appropriate. Why? Because if the neurodynamic test is painful, it alerts to a nerve problem, but it could be also just sensitized and not damaged. So we still have to do a neurological examination. And be aware, if we do a neurodynamic test and a neurodynamic test is negative, there still could be, of course, a nerve problem. So we still have to do our neurological exam. Yeah, so less appropriate palpation and neurodynamic testing. Then, of course, when we do our assessment, it's important to understand what is the state of the peripheral nerve. Is there maybe already a central sensitization? So is there more an extra trigeminal sensitization at that time for that patient? And that's, of course, not always easy, but there are different tests to localize it a little bit more there. And that's what we talk in our courses, in our advanced courses, more about. When the peripheral nerve sensitization is very dominant there, we can say there is maybe possible a nerve damage or a lesion or a dysfunction. I think important in this case is that we understand the underlying process of an MPSH. So again, think about the 4 clinical features, what I showed you in the previous slides, that we know, okay, probably this is an MPSH. But of course, it's not always easy to say, hey, it's more this or it is more that. So we have a very nice questionnaire here. And that's the LANGS questionnaire. And the LANGS questionnaire stands for the Leeds Assessment of Neuropathic Symptoms and Signs. I have an example here in the next slide. We have different items with yes or with no, but gives different numbers in score. We talk about sensitivity. Is there more shooting pain, bursting pain? Is there maybe already evidence of a mechanical allodynia? And if you do the test, we know that if the score is above 12, it indicates the presence of a neuropathic pain, so the MPSH. And yes, of course, I know there has to be a cutoff point on 12. It could be also an MPSH when there's 11 or 10, but in this case, there has to be a cutoff point, so that's above 12. It's very simple to see the questionnaire when you look on internet on it, the LANGS score. Leeds Assessment of Neuropathic Symptoms and Signs. So when we look at management, then it's important to reduce, and we have a reduction of abnormal processing of the afferent inputs. So there is a sort of inputs there, afferent information, in this case an AEGS, abnormal impulse generated size, and we have to do a reduction there. Important to emphasize here, no mobilization of the nerve system. So when we do a slider there, when we do local movements of the nerve, you can imagine if there is a lot of pain there or dysfunction, in this case, it also leads to a sort of blow up of the whole system. So it gets irritated, and automatically you will see, maybe already within your first treatment, that it gets more painful. So that's not helpful to do a mobilization of the nerve system itself. What you can do, of course, there are a lot of things to talk about now. It's not our topic today, but think about maybe other things like graded motor imagery, facial recognition programs, what we also use on the Crafter courses, but also what you can see on the internet on the crafter.org site. A lot of things to talk about, but that's not the topic for today. So the second classification is the compressive neuropathy, or in this case, compression neuropathy. What is the reason that this guy here has pain in his face? There could be a very minimal lengthy pressure, on the cranioperipheral nerve. So it's not always a big thing. It could be a very small, minor thing, but can lead to a pressure on the cranioperipheral nerve. And we know that compression, damage of the peripheral nerve system, does not necessarily cause symptoms, because we know when there is an MRI, they see something there. Hey, this could lead maybe to a herniation or something else. It doesn't mean that there is always a dysfunction there or pain. So in this case, when we talk about the orofacial area and we talk about pain, yeah, it could be without pain. So think about dysarthria, talking problems. Think about an hemifacial spasm, also without pain in some cases. Think about a facial paralysis, but also think about diplopia, seeing double. The feeling is different when we look to other things. Yeah, so it could be also without pain. I think that's an important thing to remember here. So let's go back to our case, the case of Maria, which I showed you in the first part of this lecture of the webinar. How can we assess this? Now, I of course started with the LAND score, and LAND score, what we saw that there was not a number above 12, so there was a negative LAND score. So then our next classification is, hey, this could be maybe compression neuropathy. So what I did, I treated the mechanical interface of her jaw. So in this case, that means I can talk about all the examination now, but I treated in this case the pterygoid muscles, in this case the lateral one and the medial one. And we know that it isn't mechanical interface for the lingual nerve and also for the alveolaris inferior, which is running through the muscle. So when I treated the muscle there, have a reduction there, we also saw that, in this case, I saw that the pain was getting less. Normal opening, the pins and needles changed on her chin, and within 2 or 3 sessions, her pain was gone. And what was the reason that it was better? Yes, of course, when we do accessory movements of the jaw, we know we also have an involvement of the nerve. But if you don't know about the underlying process, it still can lead to problems. So this is a typical nerve problem and not a joint problem, an arthropathy. So important to understand that how we can treat it in this situation, and in specific here in this case of Maria. Is this now a typical numb chin syndrome? I don't think so. Of course, we see it very local on her chin. That's also an example for when we talk about the compression neuropathy. It's involvement of the mental or the inferior alveolar nerve. Again, what we can call the numb chin syndrome. But be aware, it could be also a case when there is a typical numb syndrome. It's still there, or it's mainly only there. It could be also a case for another problem. Think about MS, multiple sclerosis, or maybe there are some other problems there. So, of course, yes, there is a nerve problem. Yes, it's still very good to treat. But if it's still there, it could be also a case for maybe other problems in the nerve system. Be aware of that. Other example, think about the microvascular compression of the trigeminal nerve in the CPA. And we know that if there is a compression, and CPA is the cerebral-pontal angle, so that's the area behind the brainstem, a little bit before the cerebellar area. If there is a compression there, it could lead, in this case of a microvascular compression, to problems in the trigeminal nerve. So that's a classical situation there for a compression neuropathy. Other case, again, it's a simple body chart, but I think it's nice to see that the lady here has a very specific problem on her jaw in the red area. It looks like the masseter in this area. She said to me, Daan, it gives me a fatigue feeling. I have some headaches on the temple, and sometimes I have some problems on the suboccipital area. Of course, it could be a muscle. Of course, it still could be also, of course, the neck itself. Think about the cervical spine, the involvement of the cervical spine also in this area. But in this case, it was more, of course, a nerve problem. To give you a little bit more details about her, she had a history some years ago, 4 or 5 years ago, where she had an operation. She had an angle class 2. They did an operation there. What you can see here, they placed some extra material on the jaw to fixate it. And after that, her problems was that she had problems on her masseter area. And within the upcoming months, there was also headache and extra, after that, suboccipital pain. Now, what you can do in this case is also what they did. They removed the material. Maybe it was giving her problems there. And also after they removed it in the hospital, it was still there. So she came to me and she asked me, Daan, can you look further in this situation? So I tested her. Of course, I did first my classification with the MPSH test, what we know from the LAND score. It was less than 12 in this case. So there was not an MPSH. So the next step again is the compression neuropathy. I did my sensibility testing with soft tissue, which you can do with your cotton swab. You can do it with a pinprick. Maybe you can do it a little bit more with 2-point discrimination. Of course, it's up to you what you can do there. And it's very clear on this photo that it is in the line of the mandible nerve. Also very nice to see. It stops in the mid part, so it's only having an involvement of her left side. Also part of the lip. Also what we can see here when we look to this picture. Specific in the line of the nerve. So I will come back later what the result is of her treatment. Again, there is a negative LAND score. So that's the first thing what we have to do. And of course, it has to fit within the ISPA, the guidelines for neuropathic pain. And we know that it can react a little bit different when we compare it with an MPSH. Sometimes it looks a little bit like that, but when there's a negative LAND score, we know it is more a compression neuropathy. Be aware when we do our clinical testing, it's not always painful, so that's important to understand, but it's mostly associated with activity. Think about posture that increase compression of the involved neural structures. Think about posture of the neck, maybe sitting at the desk, maybe sitting in the car, and mostly postures of the neck itself, which can lead to problems and is maybe associated for compression in the neural structures. We know there could be a loss of neurological conduction, what we already discussed, but also think about a change in adjacent tissue of the nerve, so the tissue around the nerve itself, specific when it's a long-lasting problem, it can also change. Again, think about our QST testing, what we already discussed, and of course, radiological and electrodiagnostic evidence may support in this case. Less appropriate is our neurodynamic test and palpation. It could be minimal, moderate, positive, but mostly we can see that they are less appropriate to do, and we do more with our conduction tests. Okay. So there's also another questionnaire what we can use here. Very interesting to look also to these 4 criteria when we talk about the grading system of a compression neuropathy. But it's always difficult. There has to be a confirmation also with an MRI, and most of us are not having an MRI in our clinic. So that makes it sometimes difficult to say, hey, this is a typical compression neuropathy. When we do our assessment here, we have to find out what is the localization of the compression area. Is it possible? Can we look where it is? Can we find it? And of course, in our assessment, it's important to advocate a normal functional movement of the peripheral nerve without severe inflammation. And that's important that we always do our reassessment, our test, treatment, and assessment again to see, are we on the right area? Are we on the right spot in our assessment? So we have to do in our management a decompression of the regions of the nerve, of the surroundings of the nerve itself. So what I did in this case with her, this was after the first treatment, within the trial treatment itself. I treated her on her jaw in this case. I did some other things around the nerve itself. Also think about the muscle, think about accessory movements of the jaw, also involvement of the neck. And we can see automatically that in this case, the chin was still there. And that's what we see when there is a long-lasting pain. We see normally that the distal part could be get a little bit slower in reaction, but already the whole area here in the line of the mandible nerve was okay. So within one treatment, her facial irritation, her dysesthesia, was already gone. Then the important thing, of course, is how is it after maybe 1 or 2 weeks? And when I saw her back, her fatigue feeling of her muscle was gone. She had the feeling it was a muscle, but it is really a nerve problem. So the conduction in this area, also a little bit about the surroundings, was the problem in this
Ay,
case.
hemen gidelim.
So that was the second
Telefonum
classification.
çekmiyor.
Then we go to our third peripheral nerve sensitization classification. So number 3, the PNS. And what is the reason in this case that this lady here waiting on the metro has pain around her chin, just as an example. We go back again to our 2 types of pain. So we have the nerve injury action, so the action itself that we already discussed, but now we go more to the nerve trunk pain itself. So the orange area, and also think about the connective area around the yellow part, the connective tissue. We know with this classification that the nerve trunk, the connective tissue, becomes sensitized, which explains that pain can arise from a very minor nerve damage. And there is an involvement of the trunk. The pain could be nociceptive, and also the conduction elements in this case does not occur as a problem. So what does I mean with these two bullets? The action is still okay, what we can see in this previous slide, so the blue area, but it is a typical nerve trunk pain. So that's a big difference when we talk about this classification. Also think about nervi nevorum. We can see here, it's an old picture, but still relevant. We can see here the epineurium, we can see the perineurium in this area around the nerve fibers itself. We can see here a little bit the nervi nevorum itself running in these areas of the surroundings of the connective tissue of the nerve. Would be also can give pain in that area. So it can give pain in the connective tissue. And the nerve gets its own innervation from nervi nevorum. Think about the extrinsic vasomotor innervation, what we can see also on the blood vessels, so the sympathetic fibers, and the intrinsic innervation of nervi nevorum, again, can innervate itself. And that's also a reason when we do our palpation of facial nerves, what is actually a motor nerve, can also give pain there. And that is one of the reasons that, or an explanation that it can come from nervi nevorum. It's sensitized. So what are the appropriate clinical testing? Again, associated with activity or posture. In this case, the neurodynamic test may be relevant due to the increased mechanical sensitivity, and also the palpation may be mechanical sensitive. And in this case, again, radiological and electrodiagnostic data are not supporting. We all know it. They already had an MRI, they already had maybe an X-ray, and yeah, the pain is still there. The doctors will tell you, okay, there's no problem there because I don't see any problem in the nerve system. But we know that if there's a palpation problem there, mechanical sensitive, or maybe when we see that the neurodynamic test is positive, yeah, there still could be a problem of the surroundings of the nerve. And it could be a nerve problem there with our patient. So again, less appropriate in this case are the conduction tests, because we're not talking about the action itself, but we're talking about the surroundings, the connective tissue. When we do our assessment, we have to detect the mechanical sensitivity. Where is it? Where is it increased along the nerve? And that's, of course, not always easy. But if you know the areas where we can palpate, we can say, hey, this maybe is the area where the nerve is sensitized. And also think about the associated adjacent tissue around the nerve itself could be related to an increased mechanical sensitivity. Simple case, again, another one. If you look to the body chart, very simple, only pain at her left jaw. And what was the reason that she had pain? The lady was, I think she was around 22 years old. She had her own shop with flowers. And on a Saturday morning, she was asked by the phone, okay, can you come to the funeral? Because we want to have the flowers there, because she was given the flowers for the funeral that day. And she had to go to that area. She came in a room there, and there was a dead body lying there because of the funeral. And she was a little bit in shock because it was the first time she saw someone who's dead. And she was a little bit shocked. Hey, what's happening here? I'm alone here. I'm only bringing the flowers. And at that time, she told me, Daan, at that time, I have pain in my jaw. And I asked her, is it already before? No, it was only after that moment in the room, and after that I had pain. So it looks like a very simple body chart. Could be the joints, could be the muscle, and of course in this case it was more a nerve problem. What is the reason? If you can look to the reason why she had a problem there, maybe it was facial expression. She was a little bit in shock. Maybe she opened her mouth very quickly. Oh, hey, what's happening there? So there could be a lot of reason that maybe the nerve was getting irritated at that time. When she was opening her mouth, it was very clear that when there was a deflection of her jaw, we can see here an opening of her mouth, starting with 0, opening till 50 or 60. And when she was opening her mouth, it was around 47 millimeter, and there was an opening only to one side, in this case to her right side. So there could be an involvement of the other side, because we know when there is a deflection to one side, maybe one is stiff, the other one is normal, and maybe it's an hypofunction of the jaw. So it could be an arthrogenic problem, of course. But of course, I started again with our questionnaire, with the Lens score. There were no signs and symptoms of conduction problems, so also the compression neuropathy was not there. And in this case, it was a very clear peripheral nerve sensitization. Her palpation was painful, her neurodynamic test was positive on the mandible nerve, also a little bit about the maxillary nerve. So I did my soft tissue or my superficial touch. I looked at it, I did my pinprick in that area, and what we see here, it was now involved on the big area. It's not only on the line of the mandible nerve, but also it was extra hypersensitive in the area around the second part. And the second part is what I mean with the trigeminal nerve number 5-2. So you can see it's already a little bit more than only on one nerve within the trigeminal nerve. So I treated her. Connective tissue around the nerve itself, and within one treatment you can already see that her nerve was less irritable when I do my superficial touch and my pinprick, and after 1 week we can see already that also it gets smaller, smaller and smaller, and within 2 or 3 sessions the pain was gone. So it was a typical peripheral nerve problem. So again, when we look about management, there has to be a reduction of the mechanical sensitivity of the surroundings of the neural area, and think about also of the movement itself of the jaw. So think also about, you have to promote a normal movement, functional movements. So it's not only treating a nerve or the surroundings or the axon itself. You also have to do maybe something with stimulation and activity of the target tissue, facial expression, eating, swallowing, tongue position, and so on. It's not only one target tissue, but in this case, because of 5-3 and 5-2, it's more the tissue of the muscle of mastication, and of course also the skin, because number 5-2 is only having a sensibility function. We now emphasize a little bit, maybe too much, but the trigeminus, of course. When we look about different nerves, we always try to test first the neck movements. Maybe there's a K for something else, or maybe there's a red flag. If that's okay, we test our second category, and it could be the trigeminus or the facial nerve, but also think about hypoglossus nerve. I see a lot of patients in my clinic who have hypoglossus nerve problems. Yeah, maybe of conduction problems, maybe something else which could happen there after surgery, or maybe after cancer. But it could be also a little bit just irritation of the nerve of the hypoglossus, but can lead to problems in the jaw area. So don't think only about trigeminal nerve, also involve other nerves, what we can test with a neurological examination, and what we can test with palpation and our neurodynamic testing. And our subjective testing and examination, of course, will lead to new hypotheses in our clinical thinking. It's not only that, also think about when we look at the green area here, the third category, think about glossopharyngeal nerve, think about vagus nerve, or maybe there are some eye problems there. Is it so simple like this? Yes and no. Sometimes it is simple. On the other hand, there could be also, of course, an overlap. And we look about classification. It's not only so simple like that. I think it's a very helpful tool. Also, what I showed you, how you can examine it, how you can assess it, and how you can treat it. But it could be an overlap. In this case, there could be a very big peripheral nerve sensitization, but with a little bit compression neuropathy. So think about a scar tissue who presses, in this case, on the hypoglossal nerve for making movements of the tongue, in this case, after an operation. Could be also in the opposite way. There's a little bit peripheral nerve sensitization, but it's much more a compression neuropathy. Again, what I already showed you in one of the cases, there could be a compression of the lingual nerve in the pterygoid lateral muscle during an active protrusion of the muscle of the mandible. We know that the pterygoid muscle, where we protrude the jaw, it's the main function of that muscle, maybe can have an involvement of the null and what leads to a compression neuropathy of the specific nerve, in this case, the lingual nerve. Then we have, of course, the MPSH. Think about an idiopathic trigeminal neuralgia with maybe already a spontaneous demyelination of the nerve. Yeah, but also can lead to a lot of problems, of course. But there still could be a little bit peripheral nerve sensitization. And of course, there could be also a combination of it, that all the three classifications are there. And in this case, it's about an inflammation of the cerebri posterior artery of the trigeminal nerve within the area of the cerebral pontal angle. And of course, it gives a totally different dysfunction and history. When we look about contributing factors, when we talk about neuropathic pain, there's an interesting study from Voda a little bit longer ago, but still relevant. There could be risk factors there where we can look at. So think about hormonal factors. Think about local inflammations or medical problems there. Think about minor nerve trauma, but also we know that nerves also react on physiological factors. When there is stress, when there is a live event, it also can give nerve problems and irritation. So that could be a risk factor. What can lead to neuropathic changes? So there could be a central sensitization. There could be, in this case, where we talk about a peripheral sensitization. Also think about all the different systems of the hyper and hypoactivity of the descending control systems of the body, which could lead to an idiopathic orofacial pain. So already a little bit a summary of tonight. We can see here an overview of the MPSH on the left side, what we can test with the Land score. It has to be above 12. Is there a neurological defect? So we do our neurological examination there. Is there a compression neuropathy? And what we can do, of course, the third one, the PNS, is the nerve strength sensitivity. Is there a peripheral nerve sensitization there? If it's not these three classifications, it still, of course, can be a musculoskeletal problem. So first, and I think that's the key for today, for tonight, the order of diagnosis should be first an MPSH, then we talk about maybe there is a compression neuropathy, and then maybe there is a peripheral nerve sensitization, and then maybe it can lead to a musculoskeletal pain problem. So how can we test it? Once again, as a summary, first of all, there has to be an absence of the Land score. So it has to be less than 12. It's above, maybe it is the MPSH. If it's lower than 12, the next priority is the compression neuropathy. If it's not in compression neuropathy, then it could lead that there is maybe an peripheral nerve sensitization, and there is presence and signs of mechanical sensitivity of the neural tissue. So we do our palpation and we do our neurodynamic testing. Finally, in the absence of any of these features in the previous three criteria, patients would be classified as having a musculoskeletal pain. Yeah, so of course, it still could be a typical muscle pain, what you have here. Maybe it's just only cervical spine. Maybe it's just only hypofunction or hyperfunction of the joint of the jaw. Yeah, so a very nice classification, I think. And also the order, again, is first MPSH, then compression neuropathy, then PNS, And then maybe it could be a musculoskeletal problem. Harry van Piekaerts already had a very interesting article here with some other colleagues about evaluation of the somatosensory testing, what we can do about neurodynamics within the trigeminal nerve, within the craniofacial area, a matched case control study, where he already discussed within his group about a classification where we talk about today. So maybe that's an interesting article also to read. So I hope that it gives you a little bit more light about the nerve problem. It's not only a central nerve problem. It's not only something that we have to do without our hands. We can actually use our hands, hands-on, but you have to be aware, where are we, the underlying situation of an MPHH, a compression neuropathy, or a peripheral nerve situation. And that makes it easier for you to assess it, to examine it, and to treat it in a proper way.